Hey guys, just give me a thumbs up if I'm audible. Let me tell you clearly that we are not able to find out what is the bug or what is an issue, why some of you are not able to hear the audio in both the headphones. We are looking for it. Once we find the bug, identify it and correct it, hopefully the subsequent videos you will be able to get a clear audio. For now, apologies from my end as well as from the team of PW. We are fixing it, we are trying to work on it. Okay. So the topic for today is going to be dysphagia or difficulty in swallowing. One of the common complaints that our patients present to, especially ENT clinics and medicine clinics. And we are not going to spend more time on this. This is a simple topic. We will spend around 20 or 30 minutes and we will understand how to evaluate a patient presenting with dysphagia, primarily focusing on clinical grounds. Now, all of us know that when someone presents with dysphagia, mostly we have to do proper investigation to identify the cause. But if you have a good clinical approach, maybe we can narrow down the list of investigations that we need to know. At least, okay, if I sense that, okay, this patient may be having dysphagia because of possibly achalasia cardia, then in that case, either I will go ahead with the barium swallow or barium imaging, or maybe I will do the esophageal manometry, right? I don't need to send him to an ENT surgeon to look into the patient's oropharynx and the larynx, right? But if I get to know that from the history that probably this patient may be having dysphagia because something wrong in the oropharynx, then I don't need to unnecessarily do the manometry, barium swallow and other investigations. Instead, I will refer him to an ENT surgeon who will directly put a laryngoscope and look into the patient's throat, and as well we might have the diagnosis, right? Okay. Nilanjana, good evening everyone. Okay, so first we will put down the basic definition of dysphagia. What is dysphagia? All of us know dysphagia refers to difficulty in swallowing, right? Difficulty in swallowing. There are some similar closely related terms that we need to be familiar with. Shabir, good evening. Closely related terms that we need to be familiar with. One of them is odynophagia, right? Which refers to painful swallowing. Both are not same, right? Painful swallowing, we call it as odynophagia, and difficulty in swallowing, we call it as dysphagia. As a rule, most of the patients who have odynophagia or pain while swallowing often have dysphagia also. To give you an example, right, if I have eosinophilic esophagitis or GERD induced esophagitis, while I swallow, I will experience pain, but I will also have the difficulty for the act of swallowing. But I cannot say the same thing for dysphagia. I can't say that, okay, all the patients with dysphagia will also have odynophagia. But almost all the patients with odynophagia will have some degree of dysphagia. Okay. Then there is one more term which frequently comes into picture when we talk about dysphagia, that is globus sensation. In some of your ENT books, you might come across another term called as globus hystericus, which basically means the same thing, globus sensation. What is it referred to? It refers to sensation of a foreign body in throat. Foreign body in throat without its presence. Okay. If you have a foreign body in the throat and you feel it, well, that is a pathology obviously, but in the absence of foreign body, many of these patients feel that, okay, there is something sticking in the throat, and that sensation is what we call as globus sensation, which can have medical reasons and it can also have psychiatric reasons. So when it is because of psychiatric reasons, we call it as globus hystericus. As you know, the word hysteria primarily points towards a psychiatric disorder. Okay. Now for us to understand dysphagia, its causes and how do we approach better, we need to quickly take a look at the physiology of swallowing. So when we eat food, right, our goal is to deliver whatever comes to our mouth to the stomach, because our digestion primarily begins. I know some amount of digestion happens in the oral cavity because you have the ptyalin in the saliva which can participate in the digestion, but as most of us know, most part of the digestion happens in the stomach and the intestines, right? So our goal is whatever food comes to mouth should reach the stomach, right? So this transfer of food from the mouth to the stomach becomes the essence of our discussion today, right? And for us to do that, we have to first make the chewing movements in the mouth, right? Create a food bolus, then hand over that food bolus to the pharynx. From the pharynx, we should make it sure that it goes to the esophagus and not land into the trachea, because if it lands into the trachea, we are introducing unnecessary foreign particles into the respiratory system, and similarly whatever bacteria we have in our oral cavity, they are getting entry into the trachea and we can develop what we call as aspiration pneumonia. Certainly we don't want to run that risk, right? So we need to have a very coordinated movements so that whatever we push from the mouth to pharynx goes into esophagus, and then esophagus has to deliver that to the stomach. The disturbance anywhere in this movement can result in feeling of difficulty in swallowing, right? So now when we look at this act of swallowing, it is a bit complex, but I'll try to make it simple. It has three phases. The first phase is oral phase. Now what happens in oral phase? Whatever food we have taken into the oral cavity, we will chew it. So it involves act of chewing plus pushing the food into hypopharynx, food bolus, because after chewing we would have created a bolus into hypopharynx. Okay. Now I want to ask you a question. When we chew, right, we are using the muscles of mastication. What is the main nerve supply to the muscles of mastication? Because if I have an issue with this nerve, I may not be able to chew. If I am not able to chew properly, right, I am not creating a proper food bolus. So then I will have difficulty to transfer improperly chewed food into hypopharynx. That's also dysphagia, right? So the main nerve is the cranial nerve 5, that is the main supply to the muscles of mastication, but various other muscles of face are supplied by 7th cranial nerve, right? Okay. Now once I have done the chewing, that means my muscles of mastication are working fine and their nerve supply, mainly the 5th cranial nerve, is working fine. After that I have to push the fluid bolus, whatever I have chewed and created a bolus, into the hypopharynx. This pushing action is done by the tongue. Now what is the main nerve supply to the tongue, which will control the motor movement? The tongue which will push the food bolus back, right, that is 12th or hypoglossal nerve. So that means I should have a normally functioning hypoglossal nerve for me to be able to transfer this food bolus into the hypopharynx. So if I have a palsy of the hypoglossal nerve, I will not be able to achieve this. Again, I will have difficulty in swallowing. Okay, so let us assume all this works fine and we have chewed the food well and created a bolus and we have pushed it into the hypopharynx with the help of the tongue, right? Now the food bolus is in the hypopharynx. From the hypopharynx, this bolus has to go into the esophagus. That phase is what we call as transfer phase, which is also known as, right, pharyngeal phase. And this oral phase is also known as buccal phase, Rahul, I have asked the team to schedule a session for fever also. As soon as it is scheduled, I will share the date. Okay. Now here is the most crucial part. What happens in the transfer phase? Once the food bolus comes to the hypopharynx, there are two possible outlets for this food bolus to go into, right? One, it can go into the trachea and it can go into the esophagus, right? Now we have to make such movements that the food goes into the esophagus and doesn't land up in the trachea, right? Now how do we achieve that? First thing we need to do is, there is the esophagus, right? If this is the esophagus, it has an upper esophageal sphincter which is generally in a closed state. The sphincter should open, right? And then the entry to the trachea should be closed. That closure is achieved by our epiglottis. So epiglottis should close the trachea and the upper esophageal sphincter should open, right? Now how do we achieve this? So the basic question is, what is the nerve supply to the epiglottis so that I can help in closure of the epiglottis, and what is the nerve supply to the upper esophageal sphincter so that I can relax it? Okay, can anybody tell me which muscle constitutes the upper esophageal sphincter? That is again an important MCQ point. Upper esophageal sphincter. No, 7th nerve has nothing much to do with the upper esophageal sphincter. Okay, so please remember, the upper esophageal sphincter is formed by 3 muscles. The most important muscle, or if you are to ask me to single out one muscle which acts as the upper esophageal sphincter, it is the cricopharyngeus muscle, the muscle connecting the cricoid bone and wrapping around the esophagus to go back and attach to the other side of the cricopharynx, right? So that cricopharyngeus muscle is the main muscle of upper esophageal sphincter. To some extent, the inferior pharyngeal constrictor muscle and a little bit of the muscle of the esophagus, all 3 together form the upper esophageal sphincter, but the most important component is the cricopharyngeus muscle. Okay. Now, how do I make sure that this sphincter opens up and the epiglottis closes? So, please remember the nerve supply to the epiglottis primarily comes from the 9th cranial nerve and the 10th cranial nerve, right. These are the two main nerve supply to the epiglottis, and the main nerve supply to cricopharyngeus muscle is also the vagus nerve itself, right. So, what vagus nerve does is, vagus nerve stimulates the epiglottis to close, right. Similarly, it elevates the larynx. So, larynx elevates and moves forward and epiglottis closes it, and once the larynx elevates and moves forward and epiglottis closes it, the chances of food bolus getting into the trachea is reduced, and the same act of vagus nerve also relaxes the cricopharyngeus muscle, and once the cricopharyngeus muscle relaxes, the esophageal sphincter opens and the food bolus gets into the esophagus. And once the food bolus gets into the esophagus, our transfer phase or pharyngeal phase is over. So, what we do in pharyngeal phase, we transfer the food bolus from hypopharynx to esophagus. For us to be effectively do this, we need intact and normal functioning of 9th and 10th cranial nerve, right. So, for us to be able to do the oral phase effectively, we need the 5th cranial nerve, 7th cranial nerve, 9th cranial nerve and 12th cranial nerve. For us to be able to do this transfer phase or pharyngeal phase, I need intact 9th and 10th cranial nerve. Okay. Once the food is transferred to esophagus, we know that there is peristaltic movement initiated, right, alternating contraction relaxation, so that the food bolus moves towards the lower end of the esophagus. And as soon as the food bolus enters the esophagus, there will be dilatation or relaxation of the lower esophageal sphincter, so that once the food bolus comes into the esophagus, right, it has an unhindered entry into the stomach, right. Okay. Now, what is the nerve supply to the esophagus? Esophagus is primarily supplied by its own nervous system, which you call as mesenteric plexus, right. And then the lower esophageal sphincter is under the upper thoracic ganglia, primarily speaking autonomic nervous system. Okay, so in the transfer phase, the food bolus that came to the hypopharynx should be transferred to the esophagus, right. Now, this transfer requires us to close the tracheal inlet so that the food does not go into trachea, and we have to open the esophagus so that the food goes into esophagus. So, we close the tracheal inlet by forward and anterior movement, like forward or anterior and upward movement of the larynx and the closure of the epiglottis. This is primarily mediated by 9th and 10th cranial nerve, and behind that we have the cricopharyngeus muscle, which is constricting the esophagus, that has to relax. So, that is also mediated by the vagus nerve. So, I relax the cricopharyngeus muscle so that esophagus opens up, so the passage of food to the esophagus becomes easier, and I close the epiglottis so that the passage of food to the trachea becomes impossible. So, for me to do this, I need 9th and 10th cranial nerve to be able to work perfectly fine. Once the food goes into the esophagus, it is an involuntary act, right. The peristalsis will take the food bolus to the lower end of the esophagus, where we have the lower esophageal sphincter, which will be relaxed the moment food enters the esophagus itself. It will already be relaxed, and then we will transfer the food into the stomach, and that is where the act of swallowing is complete, right. Rest of the thing is all about the digestion. Now, I can have difficulty in swallowing if I have problems in the oral phase, if I have problems in the transfer phase, and if I have the problems in the esophageal phase, right. Primarily esophageal phase is where peristalsis is happening. Okay. Now, when I have problems in oral or the transfer phase, we can call it as higher dysphagia or high dysphagia or oropharyngeal dysphagia. And when I have problem in the esophageal peristaltic movement or other issues with the esophagus, and that is why I am experiencing dysphagia, we call it as esophageal dysphagia. Okay, clear? When we have problems in oral phase or transfer phase, we will call it as high dysphagia or oropharyngeal dysphagia. When we have problem in the esophagus, we can call it as low dysphagia or esophageal dysphagia. Clinically, we can only understand the differences between these two. To go to the exact diagnosis, we need investigation, right? So, today we will learn how to differentiate whether a patient has got the oropharyngeal dysphagia or whether he has got the esophageal dysphagia. Okay. So, first we will make the list of causes for dysphagia. As I have already told you, oral phase and pharyngeal phase, if there are problems, we call it as oropharyngeal dysphagia. If there is a problem with esophagus, we call it as esophageal dysphagia. Okay. Now, what can go wrong with the oral and the pharyngeal phase of dysphagia? We just learned that intact functioning of various neurons is important, right? Various nerves is important. So, if there are problems with those nerves, we can have oropharyngeal dysphagia. Okay. So, the first thing that comes to my mind when I have to talk about the neurological cause for oropharyngeal dysphagia is the bulbar or pseudobulbar palsy. Bulbar or pseudobulbar palsy. Can anybody tell me what does this mean? This is one of the common points that examiners ask during your neurological case discussion. High because anatomically higher portions of the upper GIT, right? The oral and the pharynx are higher portions of the upper GIT, and esophagus is the lower portion of the upper GIT, right? Okay. Can anybody tell me what is the difference between the, like what is this bulbar or pseudobulbar palsy? In neurology, which part of the nervous system we call it as bulb? Which part of the nervous system is called as bulb? Okay. So, when you look at this anatomy, right, I was showing you this image. Okay, Nilanjan, right, you are right, olfactory bulb is also called as bulb, but in neurology, when you look at the brainstem, right, this brainstem also kind of looks like the inverted bulb, right. So, in neurology, bulb also means brainstem. So, if you have problems with the cranial nerves originating from the brainstem, right, we call it as bulbar palsy. Bulb refers to brainstem. Now, what all cranial nerves originate from the brainstem? We have 12 cranial nerves, right. We know cranial nerve 1 and 2. They do not have much to directly do, or they do not originate from the brainstem, right, olfactory and optic nerve. They originate from the olfactory epithelium and the retina. But remaining all 3rd to 12th cranial nerve, they have their nuclei in the brainstem, right. So, if you have problems with these cranial nerve nuclei, we call it as bulbar palsy, right. So, if I have such problems, right, 3rd to 12th, we can roughly refer to as bulbar palsy. The most vulnerable ones are the ones which are there in the medulla. Okay. Now, which cranial nerve nuclei are there in the medulla? Which cranial nerve nuclei are there in the medulla? Okay. So, those who are not familiar with the cranial nerve nuclei which are present in the brainstem, I will give you a simple hack to remember. Okay. So, let me say this is my midbrain, this is the midbrain, and then this is the pons, okay, and then I have the medulla, right. Let me call this as medulla. As we just learnt, we have 12 cranial nerve nuclei. 2 cranial nerves have nothing to do with the brainstem. Remaining 3rd to 12th, they have their cranial nerve nuclei in the brainstem. Okay. And as we know, there are 12 cranial nerves, right. So, let us divide them into batches of 3. First 4, next 4, next 4, right. Now, can I say that pons is the middle portion of the brainstem, right? Midbrain, pons, medulla. So, pons is the middle portion of the brainstem. And let me make an important statement. Out of the 12 cranial nerves, 4 of them have their nuclei above the pons, 4 of them have at the pons, 4 of them have below the pons, right. So, first 4 are above the pons, next 4 are at the pons, next 4 below the pons. Among the first 4, we know that first and second have nothing to do with the brainstem. So, remaining 3rd and 4th cranial nerve nuclei are there in the midbrain. Then 5th, 6th, 7th, 8th, 5th, 6th, 7th and 8th cranial nerve nuclei are there in the pons. Now, remaining 4, 9, 10, 11 and 12, these cranial nerve nuclei are there in the pons, okay, in the medulla, right. And now, we just learnt that these 9, 10, 11, 12 cranial nerve nuclei are very, very important for the act of swallowing. So, if there is a lesion or a tumor or an infarction or some problem here, this will result in difficulty in swallowing, because all these muscular movements that we just learned will not be able to carry them out. So, we will have difficulty in swallowing, right. So, when there is a problem in the brainstem, particularly medulla, we call it as bulbar palsy. Okay. Now, what is pseudobulbar palsy? See, all these cranial nerve nuclei are not autonomous, they are not independent, right. For example, The 10th cranial nerve, we know that it is concerned with the act of speaking. The vocal cord movement is regulated by 10th cranial nerve. But will it move autonomically on its own without me trying to speak? No, right? It will produce the words exactly what I want to say. That means I have a voluntary control on my 10th cranial nerve. From where that voluntary control comes? In the brain we have motor cortex, and there will be something called as cortico-bulbar tracts. Remember, bulb refers to brainstem, cortex is cortex we know, right? So from the motor cortex of the brain, there will be neurons which are coming to control these cranial nerves. We call them as cortico-bulbar tract. So if I have a problem in the cortico-bulbar tract, again the neurons which are originating from the bulb, they will not be able to work. Such cases we call it as pseudobulbar palsy. Today you don't need to really worry much about bulbar or pseudobulbar palsy. Just remember that when we say bulbar palsy, we are referring to paralysis of the nerves or the loss of function of the nerves which are originating in the brainstem, particularly medulla, because these are required for the act of swallowing, right? Can anybody tell me where else these nerves play important role? Like if I have to say symptoms of bulbar or pseudobulbar palsy, one of them we are talking about it, that is dysphagia. What other symptom it can lead to? What other symptom it can lead to? See, if I have to talk, what all cranial nerves are required for me to be able to produce the words effectively? Provided my Broca's area, Wernicke's area, they are all working fine, right? So I am sending the words, the signals to the vocal cords, and it is generating voice, right? So which nerve is regulating the vocal cord? Your recurrent laryngeal nerve, which is part of your vagus nerve or 10th cranial nerve, right? Now if my vocal cords produce a sound, is that exactly how my voice comes out? No, right? All of us sound differently, right? Sonu Nigam is always melodious, while Himesh Reshammiya sounds melodious only when he brings his nose into the voice, right? So we again modulate the sound that is generated by the vocal cords at the level of the pharynx and at the level of the oral cavity as well as nose. So for that, again, the contraction of the pharyngeal muscles, which is primarily regulated by 9th and 10th cranial nerve, comes into picture, right? Then the tongue movement, because see, some words we cannot produce without tongue touching the palate. Some words we cannot produce without lips touching each other. So again we need modulation at the level of oral cavity, which is supplied by 5th, 7th, 9th, right, 10th, 12th cranial nerves. So all these cranial nerves are important for the production of voice. So if I have inability to produce the voice at the vocal cords, we call it as dysphonia. And if I have inability to modulate it at the level of my pharynx and oral cavity, we call it as dysarthria. So these three things, dysphonia, yes, you can also address it as hoarseness of voice. Dysphonia or hoarseness of voice, dysarthria and dysphagia. These three symptoms are called as triad of bulbar palsy. So please remember today, we call it as triad of bulbar palsy, which includes dysphagia, dysphonia, not able to properly produce voice at the level of vocal cords, and the third one, not able to modulate this voice to sound proper, we will call it as dysarthria. This is what we call as the triad of bulbar or pseudobulbar palsy. Now my question is, can anybody give me one example where, one disorder where this bulbar or pseudobulbar palsy can happen? I will give you a clue. There was a famous scientist who gave us a lot of understanding about the black holes, right? Whatever we know today about the black holes, the Big Bang theory and expansion, a lot of it stems from his research. And unfortunately, he was confined to a wheelchair and he could not speak. So whatever he tried to communicate, we used to hear it through an artificial machine called as voice synthesizer. So Tapa, not Stephen Johnson, Stephen Hawking, right? Stephen Hawking, who was suffering from amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis, which is a motor neuron disease. Now what does that mean? We are saying motor neuron disease, means those are the diseases where motor neurons get damaged. Motor neurons are there in the cranial nerves as well as spinal nerves. So if there is a damage to these motor neurons means the neurons which are concerned with movement of muscles. If they are damaged, the muscles will not be able to move, right? So that is an example. So we can have bulbar or pseudobulbar palsy in motor neuron diseases. Motor neuron diseases. So that is one example, one classical example for someone presenting with dysphagia. Amyotrophic lateral sclerosis involves both upper as well as lower motor neurons. That's why we have named it as amyotrophic lateral sclerosis, where amyotrophy refers to muscle atrophy, which is a feature of lower motor neuron damage, and lateral refers to lateral corticospinal tract, which refers to upper motor neurons. Okay, then can anybody tell me another example where I can have difficulty in swallowing because of impaired contraction of the muscles of the oropharynx, oral cavity, or the neck level? You are familiar with the disease, that's why I am saying. I will give you clues. These are the patients where their proximal muscles become weak, and the first muscle that becomes weak is the levator palpebrae superioris. Sharon, yes, Parkinson disease can also affect the motor neuron functions. So we can have the neurological dysphagia. But I am specifically giving you clues. These are the patients where the first muscle that becomes weak is levator palpebrae superioris, and because of that they present with ptosis and diplopia, right, myasthenia gravis. So many patients with myasthenia gravis do develop dysphagia. So myasthenia gravis is another example where you can have oropharyngeal dysphagia. Okay, if you have a stroke, right, stroke involving the brainstem, we can have the oropharyngeal dysphagia, right. If there is a stroke in the brainstem, if I have a stroke here, the 9th, 10th cranial nerves are gone, obviously I will have oropharyngeal dysphagia. Okay. Then even patients with Parkinson disease, as someone commented, can also have oropharyngeal dysphagia. In Parkinson disease, the oropharyngeal dysphagia is because when you study about Parkinson disease, you come across a word called as bradykinesia. What is the meaning of bradykinesia? Kinesia refers to movement. Brady refers to slowness. So there in Parkinson disease, all the muscles become very slow in moving. So the contraction of your oropharyngeal muscles, the tongue muscle will all be slow. Because of that, they will have difficulty in transferring the food from oral cavity to the esophagus, right. So these are all neurological causes for oropharyngeal dysphagia. What are the anatomical causes? If there is something obstructing, right, if I have, let me say, large tonsils which are coming towards the center, that can cause an obstruction. So any obstruction can become an anatomical cause for oropharyngeal dysphagia. Two things are particularly important for us to remember. One of them is, which you study in ENT in sufficient detail, that is called as Zenker's diverticulum, and another one is if behind the pharynx, if I have an abscess, we call it as retropharyngeal abscess. The abscess will be protruding into the pharynx and thus making the pharyngeal size smaller or narrow, and their food can get stuck, or we will have difficulty to pass through that narrowed pharynx. These are anatomical causes for oropharyngeal dysphagia. Okay. Then we have this esophageal. Nilanjana Roy, what is this Zenker's diverticulum? There is a small anatomical vulnerable space between your inferior pharyngeal constrictor muscle and cricopharyngeus, through which your oropharyngeal mucosa can herniate to give rise to a diverticulum, like you can see in this image, right. So we call that anatomically weak portion as Killian's dehiscence. Okay, more on that you will definitely study. It's a major topic when it comes to ENT, but yeah, that is one of the anatomical causes. So if there is such a large diverticulum, right, you can see that it is literally compressing the cricopharyngeus muscle. It will not allow it to relax. So how will I be able to transfer the food into the esophagus when it is not letting the cricopharyngeus move efficiently? So I can have oropharyngeal dysphagia in such cases. Okay. Then when it comes to the esophageal dysphagia, as we know, the movement of food through the esophagus is primarily an act of peristalsis, right. So if I have problems with peristalsis, we will call it as motility disorders, and sometimes there can be a mechanical obstruction. There may be a tumor in the esophagus that will create the obstruction to the flow of the food, right. So esophageal dysphagia can be either because of the motility disorders. There are two important motility disorders that we need to remember. The first one is achalasia cardia. Again, this is an important topic. We will discuss more on that subsequently, and it is a major topic in ENT as well as surgery. The second one, it is called as diffuse esophageal spasm. Diffuse esophageal spasm. These are disorders of esophageal peristalsis. Okay. Then what can cause the mechanical obstruction? For now, I want you to remember only one cause, which is the carcinoma of the esophagus, right? If there is a cancer originating in the esophagus, it will make the esophageal orifice smaller. It is eating up the space, so food cannot pass through it. So now we have understood the causes for dysphagia. How do we classify? As oropharyngeal dysphagia and esophageal dysphagia. Now esophageal mucositis. Then you might come across another term. There is sometimes a congenital ring in the esophagus called as Schatzki's ring. Schatzki's ring. They can also cause the obstruction to the flow of blood, flow of food. Similarly, you can have eosinophilic esophagitis, recurrent reflux of acid from the stomach coming to the esophagus, causing the mucositis, what you call as GERD esophagitis, esophageal webs. These are all causes for the mechanical obstruction. So they are all obstructive or mechanical causes, and we have the dysmotility causes. Now the real question is, because if I have to diagnose these, right, for example, if I have to diagnose a Schatzki's ring, or if I have to diagnose the esophageal mucositis, or if I have to diagnose the GERD, probably I might need to do the endoscopy, right? If I have to diagnose achalasia cardia, I might require a barium imaging or esophageal manometry. For diffuse esophageal spasm, again I would require esophageal manometry. If I have to diagnose Junker's diverticulum, I need to involve an ENT surgeon to look into the patient's oropharynx, right? If I have to diagnose a retropharyngeal abscess, I need a CT scan, right? So how do we come to the conclusion that whether the patient has got oropharyngeal dysphagia or esophageal dysphagia? Because once I come to this conclusion, right, half of my differential diagnoses are out, right? So how can I distinguish between oropharyngeal and esophageal dysphagia? It's not Scathy ring, it's called as Schatzki's ring, where patients have a small mucosal ring in the esophagus, and that ring creates the obstruction to the passage of food, right? So let us learn how to approach a patient with dysphagia. So when patient presents with dysphagia, first thing I want to see is whether patient has symptoms suggestive of high esophageal dysphagia. Means whatever we said, oropharyngeal dysphagia, right? What are those symptoms which are suggestive of high esophageal dysphagia? The first one, right, if I have, let me say, bulbar or pseudobulbar palsy, right, I have 9th, 10th cranial nerve palsy, 12th cranial nerve palsy, so I take the food into my mouth, it somehow with difficulty I will push it into the pharynx, right, but from the pharynx I will have difficulty to transfer it to the esophagus, because for that I need efficient working of 9th, 10th cranial nerve. If that doesn't happen, what is the fate of this food? Where it will go? It will mostly regurgitate back from the nose. Many times when you go to neuro wards, you see patients with stroke, when their family is trying to feed them, the food is coming out from the nose, right? We call it as nasal regurgitation. It points towards high esophageal dysphagia. So if there is nasal regurgitation, that suggests that patient has got high esophageal dysphagia. If along with dysphagia there is hoarseness of voice, if there is hoarseness of voice, it again suggests that patient has got the oropharyngeal dysphagia, probably because of the 10th or 9th and 10th cranial nerve palsy, right? Okay. Similarly, if patient has got dysarthria, means he has difficulty in modulating the voice, right? It doesn't sound natural, it sounds really weird. In all those cases, it is suggestive of dysphagia originating in the higher portion, that is the oral or the pharyngeal phase, right? Along with that, if patient complains of food getting stuck in throat. See, if I have a difficulty in the esophageal phase, then I would rather feel that food is somewhere getting stuck at the level of the chest. If patient says that I feel the food is getting stuck in the throat, or if he gives the history of choking, right? If he says that whenever he tries to eat, he feels like he is choking, that is all pointing towards the oropharyngeal dysphagia or high dysphagia. If these symptoms are present, right? If they are present, that means we have oropharyngeal dysphagia. As a physician, whenever I recognize that the patient has got oropharyngeal dysphagia, I end up referring him to an ENT surgeon for a proper visualization and inspection of the oral and pharyngeal cavities. But on the other hand, if these symptoms are not there, means if patient does not have nasal regurgitation, hoarseness of voice, dysarthria, and he doesn't complain that food is getting stuck in the throat or choking sensation, instead he says that I find some pain or food getting stuck in the thoracic level. In that case, it is highly suggestive of low or what we call as esophageal dysphagia. Choking means, how to describe choking? Well, choking is a common English term which means you are not able to push whatever that has come into your throat into your esophagus. So, you feel like your breathing and swallowing both are halted for a very small fraction of second. That is what we call as choking sensation. Okay, so low or esophageal dysphagia. If these high esophageal symptoms are not there, then I will count it as low dysphagia or esophageal dysphagia. And when we discuss the esophageal dysphagia, we discussed two possible causes, right? One was motility disorders, the other was mechanical obstruction. अब इन दोनों में हम कैसे डिफरेंशिएट करेंगे कि हाँ शायद ये मैकेनिकल ऑब्स्ट्रक्शन की वजह से हो सकता है या ये मोटिलिटी डिसऑर्डर्स की वजह से हो सकता है. दैट इज द मोस्ट इंपॉर्टेंट डिस्कशन दैट योर एग्जामिनर्स विल स्ट्राइक व्हेनेवर यू आर प्रेजेंटिंग अ केस विथ dysphagia. Okay, so I will list two sets of complaints here. You should tell me which one is suggestive of motility disorder. So on one side, let me say this is patient A and this is patient B. Okay, so this patient A has dysphagia to both solids and liquids, and to start with it was for liquids more than solids. He is experiencing dysphagia intermittently, not continuously, and he has history of regurgitation of undigested food at night. It can happen in two situations. Once you have Zenker's diverticulum, but in that case it will not be bland regurgitation. Food stays in the Zenker's diverticulum for a very prolonged period, like few days. So it gets acted upon by bacteria. So when they regurgitate foul smelling food particles, right? When you have esophageal dysphagia, you can regurgitate the food which is bland, okay, not foul smelling. Then he has dysphagia which is often relieved by maneuvers, like when you ask him to do Valsalva maneuver, the dysphagia get relieved, or when you raise his arms, dysphagia get relieved. These are suggestive of motility disorders, or these are suggestive of the mechanical obstruction, right? I think most of you got it right. These are suggestive of motility disorders, right? So dysphagia predominantly affecting liquids or liquids as well as solids. Most cases it starts with liquids and then it becomes evident for solids, which is intermittent, not always there, right? Intermittently appearing. Then there may be history of bland regurgitation of food at night, that is usually seen in patients with achalasia. In fact, recently concluded INI-CT had a question where you had to differentiate between Zenker's diverticulum and achalasia cardia based on the nature of the food that these patients are bringing out or regurgitating. So there they had mentioned that it was bland regurgitation, so that is pointing towards achalasia cardia. Anyway, there was an additional clue. There was a barium swallow image also. Okay, and in case of your motility disorders, the Valsalva maneuver generally activates the vagus nerve. So you may be able to get a little better work extracted from the vagus nerve by doing Valsalva maneuver, and that is why it can relieve the dysphagia. Similarly, if I raise the arms, the anatomy might facilitate easy emptying of the esophagus. So if these features are present, I will take it as a possible case of motility disorder, and in that case I will investigate. What is the investigation of choice for a diagnosis of motility disorder? What is the investigation of choice for the diagnosis of motility disorder? Is it barium study or is it something else? Bland means the food which does not smell bad, putrid or taste bad. Basically whatever food you have taken is there in the esophagus comes out. But what happens in Zenker's diverticulum, the food that you take goes into the Zenker's diverticulum, stays there for prolonged period. Usually what happens in achalasia cardia is you just regurgitate what you ate previous night. So next morning you regurgitate that. So it is staying in the esophagus for a very short period of time. So not much of bacterial action would have taken place. So when you regurgitate, it doesn't taste bad, smell bad. But if you have Zenker's diverticulum, the food stays there for 3 days, 4 days or even more, and then you regurgitate it back. So by that time bacteria would have literally made it a mess or putrefied, and because of that it smells bad. So when you regurgitate food particles which smell bad, it is not bland anymore. Okay, so if these features are present, it is, as we know, it is suggestive of a motility disorder. Motility disorder. In that case, my investigation of choice would be esophageal manometry. We no longer rely on the barium study or endoscopy. We cannot diagnose the movement disorders. Yeah, achalasia cardia may be to some extent by seeing the increased tone of the lower esophageal sphincter, you may be able to diagnose it, but it is not a very good investigation. 50% of the cases of achalasia cardia you will miss by doing endoscopy. So the investigation of choice will be esophageal manometry. Okay. On the other hand, if patient has dysphagia to solids more than the liquids and never to liquids alone, right? If a patient presents with dysphagia only to liquids, it is almost always because of a motility disorder. Achalasia cardia, nutcracker esophagus, diffuse esophageal spasm, those will be your differential diagnosis. But on the other hand, you have a patient who has dysphagia predominantly to solids, or it started with solids and later maybe in advanced cases it started affecting the liquids also, right? Along with that, if there is, instead of having intermittent dysphagia, there is progressive dysphagia, or if there is history of weight loss, it all points towards obstructive lesions, right? There may be a esophageal web like Schatzki's ring, eosinophilic esophagitis, right? Or reflux esophagitis because of GERD, or maybe a esophageal cancer. So these all point towards obstructive disorders like the cancer of the esophagus or a web. In that case, what should be my investigation of choice? So we will, in esophageal manometry, we will analyze the pressure, peristaltic changes, see pressure of the upper esophageal sphincter, lower esophageal sphincter, and the peristaltic movements. So we have parameters set for all this. What should be the normal pressure of the upper esophageal sphincter? What should be the pressure during the peristaltic contraction? What should be the pressure of the lower esophageal sphincter at rest and when relaxed? And once the food reaches the upper esophageal sphincter, within how many seconds or fractions of seconds the lower esophageal sphincter should be relaxed. So these are all parameters which we will get to know from the esophageal manometry, and based on that we can diagnose whether the patient is having achalasia cardia, diffuse esophageal spasm, or any other motility disorders. So that as we go forward, right, we will study, you will study it in ENT, surgery as well as medicine. Yes, so investigation of choice is primarily the esophagoscopy, or you can simply call it as endoscopy, because here I can directly visualize the obstruction. So if there is a Schatzki's ring, I can directly see it. If there is a esophageal cancer, I can directly see it. If there is esophageal mucositis, I can directly see it, right? So just to give you a summary, for us to be able to efficiently swallow, the coordinated movement of muscles is required, and for that normal functioning of various neurons are required. So if there is a problem with nerves, I can have dysphagia, right? Most predominantly I can have dysphagia of the oropharyngeal phase when I have defects in the bulbar origin cranial nerve, that is 9, 10, 11, 12, right? And that usually presents with the 3 Ds of symptoms, which we call as dysphagia, dysphonia, dysarthria. When they are present, we call it as bulbar palsy, which can happen in motor neuron diseases and various other disorders. Myasthenia gravis also can affect the functioning of the muscles, and even stroke or Parkinson disease can affect. In all those cases, we can present with oropharyngeal dysphagia, right? And then anatomical causes for oropharyngeal dysphagia includes Juncker's diverticulum or an abscess behind the pharynx. Esophageal dysphagia can be because of motility disorders or because of the mechanical obstruction. Now, how do we further approach it? Whenever we have a case of dysphagia, first thing I want to know is whether it is oropharyngeal dysphagia or esophageal dysphagia. That's my first step. So for that, what questions I need to ask? I need to ask, while you are eating, sir, do you bring the food out from your nose, or the food, does it come out from your nose? If he says yes, that is nasal regurgitation. That means it is pointing towards oropharyngeal dysphagia. If patient has hoarseness of voice, it is pointing towards oropharyngeal dysphagia. If patient has difficulty in properly generating the voice, right? He generates the voice, but he is not able to modulate it to sound natural. That means he has got the oropharyngeal dysphagia. Similarly, if he feels that the food is making him choke at the level of throat, not at the level of chest, not behind the sternum, that is pointing towards the oropharyngeal dysphagia. So, if he has oropharyngeal dysphagia, further investigation will be carried out by an ENT surgeon. But if these symptoms are not there, I will take it as esophageal dysphagia, and in that case I will make an attempt to differentiate whether it is a motility disorder or there is a mechanical obstruction. So, for that these points that we discussed are very useful. Whether dysphagia is more to liquids than solids, in that case I will take it as the motility disorder. If it is more to solids than liquids, then I will take it as mechanical obstruction. Similarly, in case of the motility disorders, the dysphagia will be intermittent. In patients with the mechanical obstruction, for example, there is a cancer, right? The tumor goes on increasing. As the tumor size increases, the dysphagia goes on increasing. So, generally it is going to be progressive. If there is regurgitation of food, then again I will think of the possibility of the motility disorders. And if the dysphagia gets relieved by Valsalva maneuver or raising the arms, I will take it as motility disorder. Because if I have a cancer, whether I raise the arm or make the patient ulta, tap on the back, nothing will work. The food will get still stagnated above the tumor, right? So, if patient has got progressive dysphagia, dysphagia more to solids than liquids, and the patient has weight loss, I will consider a possibility of obstructive disorder. Beyond that, further diagnosis is only possible with investigation. But if I have come to the conclusion that it is motility disorder, then instead of doing an endoscopy, I will go ahead with manometry. That will take me to the diagnosis. And if I have come to the conclusion that it is mostly suggestive of obstructive disorder, then I will go ahead with an endoscopy where I can directly visualize, right? In the subsequent sessions, we will discuss these individual disorders like achalasia cardia and the diffuse esophageal spasm and all that. For today, that's it we had. Let me address your queries. Okay, Valsalva maneuver, you will study more of it in the ENT, but I will tell you what is it. So, what we try to do in Valsalva maneuver is we ask the patient to close his nose as well as mouth, and we ask him to exhale the air forcefully. Obviously, this air cannot go out because we have closed the mouth as well as the nose. So, what happens? Inside the thorax, pressure increases. So, rise in intrathoracic pressure irritates the vagus nerve, especially the recurrent laryngeal nerve, right? Now, we know that the vagus nerve has a very complex journey inside the thorax, especially the recurrent laryngeal nerve. So, when we increase the intrathoracic pressure, the vagus nerve gets activated because of this increased intrathoracic pressure. The activated vagus nerve will have various manifestations. One of that is also, we just learned that vagus nerve is required for us to be able to do this coordinated movement of the muscles and also relax the lower esophageal sphincter. So, if I activate, I can relax the lower esophageal sphincter and make the food pass into the stomach. So, that is how dysphagia gets relieved there if we do the Valsalva maneuver. Another use of Valsalva maneuver is when we have patients with arrhythmias originating in the atria. We call it a supraventricular tachycardias. In such cases, if I ask the patient to do the Valsalva maneuver, he will activate the vagus nerve, and the activated vagus nerve, as you know, will reduce the heart rate. So, it can help us to decrease the tachycardia in such patients, right? That is what we call as, yeah. So, there are various modifications of the Valsalva. We will discuss more on the Valsalva maneuvers when we go to the arrhythmias, right? Okay. So, in clinical practice, most of the dysphasias are oropharyngeal. The motility disorders are relatively rare. Even the esophageal cancer, though the incidence is on the rise, it's still one of the not so common cancers. So, the esophageal dysphagia is less common than the oropharyngeal dysphagia. But if you take into account a very mild case of dysphagia, which is because of GERD, in that case the esophageal dysphagia will come out as common. But most of those patients with GERD, their presenting complaint is not going to be dysphagia. They come with the complaint of what we call as heartburn, right? So, if there is an MCQ asking you what is the most common type of dysphagia, whether it is oropharyngeal or esophageal, you can comfortably go ahead with oropharyngeal. Okay. Arrhythmias do not cause dysphagia, but we can use Valsalva maneuver to treat arrhythmias. But if there are like pericardial effusion, massive pericardial effusion or a mediastinal tumor, they can cause dysphagia because they will come and compress the esophagus and they can cause dysphagia. Obviously, that will be a mechanical obstructive cause. Okay. I will tell you what is bulbar and pseudobulbar palsy before we close, right? Normally, we have this motor cortex in the brain. Okay. So, let us say that this is the brain. I am giving you a cut section, and bottom of it we have the midbrain, pons and medulla, right? we were talking about the medulla. I have the cranial nerve 9th nucleus here, 10th nucleus here, 11th nucleus here and 12th here. Okay. So the 9th cranial nerve is concerned with the movement of the pharyngeal muscles. 10th cranial nerve is concerned with again movement of the pharyngeal muscles as well as the vocal cords, the epiglottis. 12th cranial nerve, as we know, is concerned with the movement of tongue, right? But many of these are under voluntary control, right? They are not part of reflex. So when I move the tongue, I can voluntarily move. I did this movement voluntarily, right? So obviously brainstem alone cannot control it. Someone from the cortex is controlling it, right? So there is motor area or motor cortex in the frontal lobe, from which one set of neurons, right, will originate in the motor cortex, and these neurons will go and supply these cranial nerve nuclei. These cranial nerve nuclei, and this tract is what we call as the corticobulbar tract. Corticobulbar tract. Why are we calling it as corticobulbar tract? Because their journey starts from the motor cortex and ends with the bulb, which is our brainstem, right? From here, these cranial nuclei, another set of neurons will make their journey to the respective muscles. Like for example, if I am talking about hypoglossal or 12th cranial nerve, it is supplying the tongue muscles, right? Tongue muscles. So whenever I voluntarily move the tongue, the signal is generated in the motor cortex. It travels through the corticobulbar tract to reach the 12th cranial nerve nucleus in the medulla, and from there through the 12th cranial nerve this will reach the tongue and the tongue will contract. That is how I am making the movements, voluntary movements of the tongue, right? So if I have a damage in the corticobulbar tract, what is the outcome? Even if I want to move my tongue, I will send the signal from the motor cortex, but will it be able to reach the 12th cranial nerve nuclei? It will not, because there is a damage to the corticobulbar tract. What is the outcome? The tongue movement will be lost. That is the outcome, because for me to be able to do voluntary movement of the tongue, I need normal functioning of the motor cortex, normal functioning of this tract, and normal functioning of the 12th cranial nerve from its nucleus to the muscle, right? So when the problem is in the corticobulbar tract, the outcome is loss of the tongue movement. But is there a problem at the bulb? Bulb is our brainstem. Problem is not in the bulb, but the outcome is loss of function carried out by the bulb. But the problem is not in the bulb, but it is above that, above the brainstem. Such patients where the damage is to the corticobulbar tract, we call them as pseudobulbar palsies. And if I directly have a tumor sitting on the 12th cranial nerve nucleus, what is the outcome? Again, there is a tumor, it will not let the 12th cranial nerve function fine. Even if from my brain I send the signal, it will come to the 12th cranial nerve nucleus, but from there it will not be able to reach the muscle. So tongue movement will be lost there also. In both cases, whether the damage in the corticobulbar tract or in the cranial nerve nuclei, the tongue muscle has lost its function. But in the first case, the problem was not at the level of brainstem. That's why we call it as pseudobulbar palsy. Now in the second case, the problem is right at the bulb. Bulb is our brainstem. So the damage is to the bulb, so we call it as bulbar palsy. Both of them, the outcome is same. The muscles supplied by these cranial nerve nuclei are losing their function. That's why collectively we call it as bulbar or pseudobulbar palsy. Both of them have the same set of symptoms: dysphagia, dysphonia, dysarthria. I will give you a small homework. So when you connect to the next class, right, you should be telling me how do I differentiate from bulbar and pseudobulbar palsy, because both the patients are going to present with dysphonia, dysphagia and dysarthria. Nuseba Abrak, because the esophageal movements are under the myenteric plexus control, right? Until and unless there is a damage to myenteric plexus, I will not have the motility abnormalities. And what happens in achalasia cardia or the diffuse esophageal spasm, there is a dysfunction of this myenteric plexus itself. But we are not calling it as neurological causes, we are rather defining it as motility disorders. But yes, the problem is in the myenteric plexus. Dysarthria refers to, no, Sutapa Samantha, loss of 12th cranial nerve function alone is not bulbar palsy. All the cranial nerves which are originating from the medulla, that is 9, 10, 11, 12, if they are collectively lost the function, then we will call it as bulbar or pseudobulbar palsy. If the problem is in the medulla, we will call it as bulbar palsy. If the problem is above the medulla, we will call it as pseudobulbar. If only one isolated nerve is affected, we will directly call it as 12th cranial nerve palsy, 11th cranial nerve palsy, 10th cranial nerve palsy or 9th cranial nerve palsy. Collectively, when multiple of these are affected, we call it as bulbar or pseudobulbar, depending on whether the problem is at the bulb or the problem is in the corticobulbar tract. Okay. Last point, the dysarthria, right? So when we talk, how do we produce the voice? The first thing is we exhale the air. When the air is coming out, our vocal cords vibrate and this air column is made to vibrate. That is how the first level of sound production happens in the level of larynx or by the vocal cord movement. Okay. But once the sound is generated, we have produced the letters like e, we have produced the letters, but what we hear is not what is produced by the vocal cords. Once this sound travels through the pharynx and mouth, we further modulate it, right? I can say na, I can say na, right? Both are na, but in the first instance, I utilized my nose. In the second instance, I only utilized my oral cavity. So we modulate that sound in the pharynx and oral cavity and nose. So when I have difficulty in modulating this sound, we call it as dysarthria. When I have difficulty in producing the sound at the level of vocal cords, we call it as dysphonia. If I cannot send the signals to vocal cord itself from the brain, we will call it as aphasia. Clear? Right. So from the term bulb primarily refers to brainstem, but when we say bulbar or pseudobulbar palsy, we are more concentrating on the medulla. So if the problem is at the medulla and because of that the 9th to 12th cranial nerve are not able to work, that is bulbar palsy, right? And if the problem is between the motor cortex to the bulb, the tract, corticobulbar tract, so if there is a lesion in that location, we will call it a pseudobulbar palsy. Absolutely right. Okay, so that's it from me today, guys. I will be sharing some MCQs, so please go through them, mostly coming from the anatomy and physiology. And in the next class, I'm expecting you to answer me how to differentiate between bulbar and pseudobulbar palsy. I will give you a clue, right? So motor cortex to the brainstem, this is carrying upper motor neurons, and in the cranial nerve from the nuclei to the muscle, it will be carrying lower motor neuron. So if you know how to differentiate between an upper motor neuron and lower motor neuron damage, then you should be able to answer this question, right? So that's it from me here, guys. I'm signing off. Good night and study well. I'll see you in the next class. The schedule will be shared with you soon. Thank you, guys. Bye-bye. Have a good night.